Welcome all. Welcome to the Fast Five at the RSNA 2023. Your colleagues from around the world submitted their ideas covering a wide range of non-clinical topics to participate in this engaging and fast-paced session. After our voting process, where all the topics were considered, 5 speakers were chosen to present today. Each speaker will have 5 minutes to present on a topic of their choice that reflects this year's RSNA 2023 theme, Leading Through Change. So, let's begin. I am your moderator, Ángel Gómez-Cintrón, a musculoskeletal radiologist at the University of Texas in San Antonio. Dr. Gaetke-Udager is an associate professor of musculoskeletal radiology at the University of Michigan, where she serves as the Diagnostic Radiology Residency Program Director and the Musculoskeletal Radiology Division Director. She received her undergraduate degree from Yale University and attended the University of Michigan Medical School. She completed her radiology residency, a musculoskeletal imaging fellowship, and an abdominal imaging fellowship, all at the University of Michigan. Kara's topic is Teaching Future Radiologists. What's in it for me? Please welcome Dr. Kara Gaetke-Udager.
Hi, I'm Kara Gaetke-Udager, and I am here to talk today about teaching and why it can actually benefit you to do it. And I want to start with the hard part. I am a radiology residency program director at the University of Michigan, the best training program in the country. I love teaching, and I love my trainees. But I'll be the one to say it, teaching isn't easy. And these days, it's feeling even worse. You walk into the reading room in the morning, and there's a huge work list waiting for you. There's a brand new R1 resident who's trying so hard just to understand the words you're using. There's an R2 resident who's just picked up their first 5 shoulder MRIs ever, and they're all complicated. And there's a fellow who's managing to look both tired and panicked at the same time. You know it's going to be wall-to-wall cases with not enough time or energy to be the teacher you want to be. But you're an educator. You know what to do. You dig deep, and you think about your motivators. You're doing this to help trainees. You are doing this because some special teacher once poured their heart out teaching you. You're doing this because this is what you think teachers do. You give, and you want to give. But sometimes it doesn't feel like enough in return. We have more and more patients, and we can't take the best care of them and teach. It feels like a losing equation. I hear all of that. As you can tell by my story, I've been there at times. But I'm here today to do something a little controversial for a teacher to do. I'm here to tell you that teaching can benefit you, the teacher. This isn't all just a bunch of altruism, but it is in fact something that can improve your bottom line, as foreign as that may be for a teacher to say. Teaching creates radiologists who are in very short supply these days. If you train them well, they will take outstanding care of your shared patients while they're in your program. You train them well, and they could be your future fellow or colleague who crushes the list with you someday. Train them well, and you could benefit from their expertise when they read a study for your family member or for you someday. Teaching builds your team's culture by creating meaningful professional relationships. When you engage with trainees, they give you their best in return. The group's enthusiasm for work, even spending time in the reading room together, grows. The positive energy of the team builds. In return, you can recruit more residents who want to be there and who want to stay there, and you retain more faculty who enjoy that environment. Teaching creates research questions and creative ideas. Trainees have lots of questions. They don't accept our answers of, well, because we've always done it that way. They see the flaws in those arguments. They know the problems with our systems, and many times they have the best solutions. They show us the way forward. Teaching keeps you sharp and skilled. It makes you a better radiologist. There's nothing like having a trainee ask you a question at the workstation that you should have known the answer to. We all get better in this way. When you teach at the workstation or give a conference, you're not just giving. You are building on what you know and learning new things. You can't become stagnant because you have bright trainees keeping you on your toes. I get that it's a huge change to think about teaching like you're getting something out of it. It's even uncomfortable, but it can have a huge impact on those busy days in the reading room or on how you build your career. It can reduce the transactional feeling of our job. It's actually a winning equation. So, what do you do when you walk out of here? Be the best teacher you can be. And in return, you will gain more outstanding radiologists in the workforce, amazing future colleagues, an incredible culture at work, ever-growing clinical expertise, constant inspiration and innovative thinking, and a practice that everyone would love to be a part of. To the teachers out there, you are killing it, and not just for those trainees you love so much, but for yourself. Thank you.
Dr. Ann Williams Darrow is a diagnostic radiology resident at the John H. Stroger Jr. Hospital of Cook County in Chicago. She will complete her fellowship in breast imaging at the University of Chicago in the academic year of 2024-25. She managed health and wellness programs for middle and high school students before returning to medical school, earning her MD from the University of Illinois at Chicago. She is on the board of directors of the American Association for Women in Radiology and is the president of the Resident and Fellow section of the Illinois Radiological Society and the Chicago Radiological Society. She has served on DEI committees throughout her schooling and career. Ann's topic is MORE, Mentoring, Outreach, and Resources for Equity. Please welcome Dr. Ann Williams Darrow.
Thank you. Good morning. My name is Ann. I'm so excited to be here today to talk to you all about this topic. It's a program that I spearheaded here in Illinois called MORE, which stands for Mentoring, Outreach, and Resources for Equity. I was so fortunate to have some mentors and colleagues, my program director, my fellowship director, and other colleagues through the Illinois Radiological Society who were very supportive of this program and helped to implement it from idea to making things happen. This program has 3 components. First is a staff training. Second, community outreach. And third, paired mentorships. The goal is that in the future we will have a more diverse workforce and better be able to serve our communities, especially underserved and diverse communities, specifically with this program focusing on LGBT communities and transgender imaging. I was inspired to learn more about this topic, and I wanted to know what the issues were facing the transgender community especially, but everyone in the LGBT community, as I had the good fortune of getting pregnant at the same time as my spouse. I am cis feminine, and my spouse is trans masculine. And so we were so lucky that we conceived at the same time. Here we are in our first and third trimesters of pregnancy. It was really cool to go through that experience together, but something that I did notice while we were pregnant and after having the babies was even the most well-intentioned doctors, nurses, and other medical professionals we interacted with sometimes stumbled through their interactions with us. They didn't always know which pronouns to use or which term to call each of us as a parent, for example. And then when I got into medical school, this was right before medical school, we had them, I noticed there wasn't a lot of training in our medical education about working with the LGBT population. And furthermore, in radiology residency, when I wanted to learn more about transgender imaging, as questions came up, not just in my family, but other LGBT friends that I talked to, pretty much everyone had had at least one awkward interaction in the healthcare setting related to their gender identity. And I think as a profession, we can do better. We can create more inclusive environments in our radiology departments. We can use correct pronouns in our imaging report. It really makes a difference to patients. So transgender patients may pursue multiple methods of gender affirmation, including medical, hormonal, and surgical procedures. It's important to keep in mind that not everybody is going to pursue all of these options. As radiologists, though, we may get a call from our primary care colleagues asking about breast cancer screening recommendations, for example, for a trans woman or a trans feminine patient. This would be someone who was assigned male at birth, who identifies as a woman, and has undergone some type of gender affirming care. So there are resources out there, I'm happy to say, in the last few years. For example, the ACR has released appropriateness criteria for transgender breast cancer screening. So if a trans woman has been on hormonal therapy for at least 5 years, for example, and has average risk, we may recommend similar screening recommendations to a cis female patient. Similarly, we all know that we might want to do an ultrasound if we're doing a paracentesis on a patient to look for the inferior epigastric artery, make sure we're not causing harm. That same vessel may be the arterial supply for a transmasculine patient if they've had a surgical neophallus created from an anterior abdominal flap. There are 3 main procedures that surgeons may choose to use for creating a neophallus: the anterior abdominal flap, anterior thigh, or radial flap. As radiologists, it's important for us to be aware of what the donor site may be, the surgical and hormonal history of our patients. So in conclusion, I really believe that we can all make a difference. We can take the extra step to know what the background of the patients are whose reports we're reading. Our patients have access to their radiology reports, and if we're misgendering transgender patients, or any patients, of course, that doesn't reflect well, and it doesn't make them feel good or confident in their care. On the other hand, if we're making an effort to use the correct pronouns, to provide the correct recommendations for imaging, and to create a welcoming environment, I think having pins, which we give out at our talks, and visual symbols of inclusivity for all groups can make a huge difference. And I encourage you all, if you're passionate about something, to pursue that, find mentors, we can all make a change. Thank you.
Cooper Gamble is a first-year undergraduate student at the University of Southern California studying biophysics. He has been working in Mayo Clinic's radiology informatics lab at the Rochester campus for more than a year, where he studies and builds deep learning tools for radiology. Cooper plans to pursue his medical and doctoral degrees so he may continue contributing to the radiology community through his academic and professional career. Cooper's topic is Artificial Intelligence Needs to Know What It Doesn't Know. Please welcome Cooper Gamble.
Good morning, ladies and gentlemen. I am Cooper Gamble, and today I want to talk to you about artificial intelligence. Let's begin with a case study, one with which I'm sure many of you are quite familiar. It's a late night in the reading room, and you've already given hundreds of reads this shift. The fatigue is starting to kick in, but all of a sudden, you encounter a particularly challenging patient. ED notes say they were admitted with a severe headache, vomiting, and loss of balance. So you know you're looking for a hemorrhage, but you just can't find it. The first thing you notice are some small high-intensity regions around the midline, but you cannot say for sure whether it's bleeding or calcification. You also observe that part of the skull seems to subtly leak into the parenchyma. But once again, you cannot definitively conclude if this is EDH. You're stuck. Now, as frustrating as this case is, it exemplifies a critical function of the human brain: the ability for us to distinguish between information we know and information we don't. AI, on the other hand, cannot do this. artificial intelligence is often regarded as a black box. But under the hood, these systems are built on nothing more than stochastic calculus and computational optimization. In other words, it's just math. Now, without spending too much time delving into the intricacies of neural networks, all you need to know is that as of now, it's commonplace for us to interpret the numerical outputs of these models as measures of their confidence. This is significant because mathematically, these numbers do not represent confidence, and interpreting them as such gives us a false definition of and sense of trust in AI. And it's exactly that, the trust factor, that brings me here today. As a community of radiologists dedicated to doing no harm and leading through change, it is our job to make AI as trustworthy as possible. And in order to do that, this year, we need to talk about uncertainty quantification. As an AI researcher, I've had the opportunity to be a part of the growth and development of AI tools as powerful systems in radiology, from hemorrhage detection algorithms all the way to addressing demographic inequity in data through generative AI. And one of the most fundamental questions our group has been researching is how we as a community can make AI trustworthy. And the answer is UQ. You can think of uncertainty quantification as a lingua franca between humans and AI to communicate the amount of unknown information about a given problem. To be concrete about this, let's return to the example from before. The state-of-the-art hemorrhage detection algorithm, which we'll say has 99% accuracy, would output some set of diagnoses. Say, for example, IPH and EDH. However, in a case as challenging as this one, it's likely that the model would actually be wrong. And it's in these 1% of cases that uncertainty becomes critically important. It would have been far more useful and much safer for the model to instead tell us that it wasn't sure and would like some additional review from a human physician. And that's exactly what uncertainty quantification allows us to do. It's a bridge between human intelligence and artificial intelligence. And it will enable us to extract the most powerful features of AI while keeping it trustworthy with human intervention. The problem is, no one is talking about it. Out of all AI-related Nature publications over the past 3 years, just over 3% have even made reference to UQ. And our community isn't doing much better, because out of all radiology articles related to AI published over the same time period, just over 8% mentioned or discussed UQ. So you may ask, what can I, as a physician whose closest interaction with AI so far has been this Fast 5 talk, do to shine light on uncertainty quantification? Well, it's simple. Talk about it. You don't have to be an expert in or even have interest in AI to wonder how these technologies are going to influence your life as a radiologist. And so, for so long, our community has placed such tremendous value on the wow factor. But in this year of change, I say, and I invite you all to join me in saying, that it's time we start thinking about the trust factor. Thank you, ladies and gentlemen, for your time and attention. And I hope I've shown you why AI needs to know what it doesn't know.
Dr. Saurabh Jha is an associate professor of radiology at Penn Medicine. He is an artificial intelligence scholar and writer. His essays have appeared in a range of outlets, including the New England Journal of Medicine, the Journal of the American Medical Association, and Forbes magazine. He recently led a team to Everest Base Camp for the highest use of artificial intelligence-enabled radiographs. Saurabh's topic is X-rays on Mount Everest. Please welcome Dr. Jha.
Thank you. The chap on the bed with an oxygen mask, he is a high-altitude porter, Sherpa, who was at Khumbu Icefall fixing ropes, the most dangerous segment en route to the peak of Everest. And he had progressive cough, which he ignored until he could ignore it no more. And we performed an X-ray, and he has fluffy opacities, perialveolar, which at that altitude you do not have the luxury of hedging, so we couldn't say pneumonia not excluded. We had to come with a diagnosis because the diagnosis of high altitude pulmonary edema, which is what he has, is very consequential. The only treatment for that is to descend. It is a diagnosis that is delayed in Sherpas because if one makes a false diagnosis of HAPE, a false positive, which we kind of take for granted down here at sea level, he loses his livelihood. And so the doctors are very reluctant to make the diagnosis until they're sure, and often when they're sure, it becomes quite life-threatening. A bunch of us got together, including industry partners, Cure.ai and MinX-ray, along with our Sherpa partners, to do something very audacious, to take an X-ray all the way up to base camp, to push the limits of imaging, which one can do in many ways, spatial resolution, temporal resolution, but we thought we would push it to the geographical location, one of the most inhospitable terrains and one where medical need is constrained by the environment. And we went along the Yak Trail. Mountains are very egalitarian. We shared the path with the Yaks and other backpackers and climbers, and we stopped at multiple Sherpa settlements to assess their medical need. One very interesting statistic, partly humorous and partly a result of the commercialization, is that in the town Namche Bazaar, which is the main Sherpa settlement, where the population often swells to 20,000 people, they have more Irish pubs than doctors. There is only one doctor, and there is no X-ray machine. Perhaps they have their priorities right. Our goal was really, quite literally, to bring the X-ray to the people, and in that, we were not unique. This was done over 100 years ago by Madame Curie, who drove mobile X-ray machines to the battlefield in World War I. If we are to democratize imaging, we need to get to the patients. The patients cannot come to us. And if you're on the mountains, it's a little bit difficult moving a portable X-ray with wheels over uneven terrain, rocks where we have to jump from one to the other. Fortunately, and perhaps rather ironically, the X-ray machine itself has shrunk, that it can now fit in a backpack, which is kind of poetic, as the route itself can now be used by backpackers. As a radiologist, a chest radiologist no less, I often look at chest X-rays one after the other. My job is to destroy the list, and that's the thinking I have. In the Himalayas, one has to think about the patient in front of them, the population, and all sorts of other considerations. So let me give you one example, the diagnostic dilemma, the consequences of a wrong diagnosis, the consequences of false positive. It's often that you have to conscript a helicopter service from Kathmandu to rescue people from base camp. That journey itself is not innocuous, and therefore the value of information, the value of making a correct diagnosis is immense. The chest X-ray that we take for granted is so valuable, and never before was I more proud of being a radiologist than I was at 18,000 feet, where I realized that imaging is not an indulgence for the rich, but a necessity for the poor. And in taking this journey, whatever we could have given to the Sherpas, they returned far more to us by their affection and their love. I'd like to thank my industry partners again, Cure.ai and MinX-ray. I'd like to thank the RSNA for this wonderful opportunity to speak in this auditorium. And to all of you, I wish you all the best of luck in pursuing your own personal mountains. Thank you.
Dr. Jessica T. Wen is a PGY4 diagnostic and interventional radiology resident at Stanford University. Her research interests focus on hepatocellular carcinoma and liver disease. She is an advocate for diversity, equity, and inclusion through her Racial Justice in Medical Research Initiative, also known as RISE. You can find more information at pledgetorise.org. Jessica's topic today is colorblindness doing more harm than good in combating racial health disparities? Please welcome Dr. Jessica Nguyen.
Hi everyone. 大家好. My name is Jess Nguyen, and I self-identify as Taiwanese American. I am the creator of a racial justice and medical research initiative called RISE, and in the next 4 minutes, my goal is to convince all of you, clinical research gurus and budding research superstars out there, why you need to report the racial and ethnic breakdown of your research cohorts in your demographics table in all of your future research studies. Since World War II, medical researchers have chosen to be colorblind because our past leaders felt that colorblindness would be helpful for racial minorities. However, as racial health disparities continue to persist, it really begs the question, how can we protect the healthcare of racial minorities if we pretend that populations of color don't exist? And the fact that we don't, it shows. During the COVID-19 pandemic, all populations of color, including Black, Hispanic, and Asian Americans, experienced case fatality rates 2 to 3 times higher than non-Hispanic whites. A deeper dive shows that racial bias in healthcare presents itself through socioeconomic factors, including the inadequate use of data from populations of color. For example, pulse oximeters, a fundamental and pervasive healthcare device, were built colorblind. Without color-conscious checkpoints in place, the use of these devices during the pandemic resulted in a phenomenon called hidden hypoxemia, and ultimately resulted in clinically significant delays in care for all populations of color, with the Black and brown populations suffering the worst disparities. With the rise of artificial intelligence and emergence of genomics-based healthcare, we know today that the relationship among race, ancestry, and healthcare, it's actually quite complex. Allow me to use my own population as an example. Due to socioeconomic factors, 1 in 12 East and Southeast Asian Americans are chronically infected with hepatitis B, as compared to 1 in 1,000 non-Hispanic whites. However, due to genetic factors, Asian women have higher breast densities as compared to non-Hispanic whites, and women with high breast densities have up to a 6-fold increased risk for breast cancer. Now, knowing this as a physician and radiologist, I would be doing a disservice to my population and all populations of color by failing to both seek out and incorporate such disparities in disease screening and surveillance. Colorblindness is harmful. So, 11 months ago, the Food and Drug Administration made history. After immense pressure by social advocates, the FDA has finally mandated that all clinical trials report the racial and ethnic breakdown of their research cohorts as part of their diversity action plan. So how can we make sure that radiology is also on the right side of history? Well, that starts with each one of you. Each of you can contribute to color-conscious healthcare by reporting the racial and ethnic breakdown of your research cohorts. That's it. You don't need to make sure that your cohort is racially balanced, and I will asterisk that unless you are doing AI research or a clinical trial, in which you should certainly try. And if you do choose to perform sub-analyses by race, please keep in mind that race is a social construct with no biological basis. And therefore, it's important to consider the role of racism and systemic inequities rather than race in the discussion of observed health disparities or lack of representative data. But if you want to keep it simple, all you have to do is report the data that you already have. How is this helpful, you might ask? Well, one, this will help you and your readers gain awareness of the racial and ethnic makeup of your cohort. And two, this can supercharge and power health disparity studies, either through intra or multi-institutional data sharing or meta-analyses. Let me translate that for you. Basically, I'm saying this can help you gain collaborations on more research projects or get more citations from your work. Here are some examples of how your contribution can change management guidelines for populations of color. As radiologists, we are the gatekeepers of disease screening, disease diagnosis, and treatment response. We are also leaders in AI-assisted healthcare and big healthcare data. The United States is a global powerhouse for research and innovation. It is our duty to ensure that we are not overlooking the 40% and growing of our current US population that belongs to populations of color. I hope you will join me in leading the change for color-conscious research. Thank you.
Thank you. Thank you all for joining us for the RSNA Fast 5. I also want to thank all the Fast 5 speakers for such outstanding presentations. We hope, really, that you're inspired by the many ways today's speakers are leading through change. Please stay around for the upcoming outstanding plenary session. Thank you.